Well, this is Manju Beier again, and this is third in our series of presentations focusing on polypharmacy and genotyping and drug-drug interactions and so on. Hope you enjoyed the last two. This one is going to be focused on opioids, pain management, and the role of genotyping. And I thought that this would be an interesting presentation as well, because many of you seem to be getting questions from your clients that might be pain physicians or dealing in psychiatry, and there's a lot of crossover, as we talked last time a couple of days ago, between psychiatry and pain. So hopefully all of you can hear me, and hopefully all of you can see the slides on the screen. Great. So I just want to get started, again for the next 30-35 minutes. I'll do the presentation, and hopefully we can have questions at the end. Maybe you can type in the questions in the chat box, or I'm not sure if people can actually ask questions online through the speakerphone. In any case, this is the second slide, and just mentioning some of the pain principles in older adults. It's very important, of course, when somebody is being evaluated for pain management, that you look for the underlying etiology, the cause. Sometimes that is very obvious, like in acute pain management due to a sports injury or something like that. But sometimes it is not very obvious, and you can have multiple conditions coexisting, like arthritic pain along with neuropathic pain if somebody has diabetes, and things of that nature. Now, looking at drug therapy, especially again focused on older adults, which is really my arena, monotherapy is the way to go, meaning one drug at a time. This is what we'd like to see in the elderly, and not have too many medications on board because of all the problems that we have talked about in terms of increased sensitivity, drug-drug interactions, and so on. So monotherapy really just implies that let's try one drug at a time and see what the expected response is, see what the toxicity is, and how the patient is tolerating. And if that is not working, then we have a term actually called, which I coined many years ago, called rational co-medication. You may look at, some people call it rational polypharmacy, which I don't really like, and I like to call it rational co-medication. Versus polypharmacy. Polypharmacy, again, as we mentioned a couple of seminars ago, a couple of sessions ago, really implies that you've got inappropriate combination of medications, and you're going to have some negative outcomes. Rational co-medication is really combining lower doses of drugs if monotherapy is not working, so that you can mediate pain relief through different mechanisms. And they may have complementary mechanisms of action, like combining a non-steroidal anti-inflammatory drug, that class which has drugs like ibuprofen and naproxen and many of these things that you can get over the counter, and combine it with a low dose of an opioid, for example. It could be hydrocodone, which is in Vicodin, could be oxycodone, could be a low dose of morphine, and that's what you're trying to do. And what you're also trying to do is anticipate, prevent, and actively treat any adverse events that may be happening. This next slide, we've talked about it many times, but just graphically, this is actually from Annals of Emergency Medicine, a nice article in that journal that looked at patients coming in on many different meds, and they looked at about 355 patients, and as you can see, people that had just 2 drugs on board had an actual drug interaction of 5.6%, but if you had 8 drugs on board, then there was a 100% chance that you were going to have a drug interaction. So that is why we try to minimize what we call polypharmacy. Just a funny cartoon that says take one every hour until the pain goes away. We have certainly gone way beyond that, because we have many effective medications that don't have to be taken every hour. They can be taken once a day, and so we have many dosage forms and many effective medications, but the problem is finding the right drug for the right patient. So some of the medication issues in pain that we have are, just like we talked in psychiatry, there is variation in individual clinical response, and so one has to, one drug doesn't fit everybody. One has to do sometimes all kinds of gymnastics to find the right drug for the right patient. Medication-induced side effects are terribly important, and not everybody tolerates the same dose and the same drug at the same time. A lot of that can be explained by genetics. There are certainly genetics underlying opioid pain therapy as well, in terms of how sensitive the receptors are, where the opioid medications like hydrocodone and oxycodone and morphine and codeine act. We've talked a lot about drug-drug interactions, obviously. We'll talk some more. And then the drug-herb interactions, as I mentioned last time also in psychiatry, are very important because people are spending a fair amount of money. They are disenfranchised from the medications that are out on the market. And, there's a lot of money being spent on garlic and ginseng and St. John's wort and ginkgo and kava and things of that kind. And St. John's wort, which is used a lot in depression, is a very powerful inducer of liver enzymes. Now, pain doesn't exist in isolation. It does exist with especially chronic pain. The cycle of chronic pain is very difficult to manage. There is anxiety, there's depression, there's other mood disorders, and it frequently requires antidepressants, mood stabilizer drugs, and therein lies the conundrum of, rational co-medication. Neuropathic pain management is also very important because many conditions do have the underlying, cause of neuropathic pain syndromes like diabetic peripheral neuropathy, long-standing diabetes. You can have that. Trigeminal neuralgia, post-stroke syndromes, and they require a fair amount of expertise in management. The next slide, I just want to show you, this is a very old slide, which is called the WHO, the World Health Organization three-step ladder. It was put into place, many, at least 20 years ago. And the first step of the ladder is what we call mild pain management, where aspirin, ASA is aspirin, acetaminophen is Tylenol, and, medications like ibuprofen and naproxen, they are in the first category. So if you have mild pain, that is what is the first line in therapy, and should be everybody should be started with that. The moderate category is a step up. If certainly the mild pain medications are not doing the job, you go on to the next level, where you have codeine, hydrocodone, oxycodone, tramadol, which is Ultram. And then finally, in the severe or the very, very third last category of severe pain, that is when you have the very powerful, very potent opioids like morphine, hydromorphone, methadone, which is a very difficult drug. It's a very effective drug, but has a long and variable half-life. There's many drug interactions to speak about, and fentanyl and oxycodone, they're in that category. You may see that in every step of the ladder, it says plus minus adjuvants, and you may ask yourself, what is that anyway? Well, adjuvants, by definition, are not analgesic pain relievers like the medications that are mentioned here, but in the chronic pain scenario, you have these medications that can be added at any time and involve antidepressants, anesthetics like lidocaine and the lidocaine patch, anticonvulsants like Lyrica and Neurontin, muscle relaxants, antipsychotics, some steroids are even added, and that is just, again, in this whole scenario of neuropathic pain or chronic pain syndrome, those drugs can be added at any time along the continuum. And so I'm just, presenting this information to you so you have some basic understanding of pain management when you talk with your clients about that are pain management specialists, so there is some basic understanding as to what they're trying to do. Some of the common adverse events of these pain medications like acetaminophen or Tylenol, we like to say that no medication can be exonerated from side effects, not even just, baby aspirin or even, 5 grains or 325 milligrams of Tylenol, because all of them have side effects, and certainly some of them, are dose dependent and certainly duration dependent, how long you're actually taking them. So for example, with Tylenol, there's, liver toxicity associated with Doses over a period of time, we try to stay under 4 grams a day. The FDA has had many meetings on this, and they have given new guidance to the manufacturers that, starting this year and next year, they should decrease their pain medication prescriptions in combination, for example, like, hydrocodone or Vicodin, not to 500 milligrams of Tylenol, but actually just to 325 milligrams of Tylenol. So it should be no more than 325. That is to decrease the amount of Tylenol people consume on a 24-hour basis. Then, of course, the non-steroidals like ibuprofen and naproxen, mostly GI toxicity, as we call it, stomach ulcers and, gastric distress and, abdominal pain. Renal toxicity can happen over time, kidney toxicity with, chronic doses of, especially high doses of these drugs. Then all the opioids have very similar kind of side effects like nausea, vomiting, and constipation. We have a couple of slides on that coming up. Tricyclic antidepressants like Elavil, we talked about it last time, that are again used in chronic pain syndromes, sedation, delirium. They have side effects like anticholinergic side effects, and also some cardiac side effects like decrease in blood pressure and cardiac conduction issues, arrhythmias, and things like that that can be quite difficult to manage. Now, I'm showing this slide again. I showed it a couple of seminars ago that, again, it's important because we're talking about opioids and pharmacogenetics, that, if you take a drug that is not a pro-drug, if you are a poor metabolizer, you're going to see more adverse events, even in the very small dosage spectrum. If you are a poor, if you're an ultra-rapid metabolizer, the bottom line, the yellow line, the drug is going to be ineffective because you're going to be metabolizing it very fast. But on the other hand, if you're a pro-drug, and there's many examples in the opioid management class, in the pain relievers that are called opioids. So if you're a poor metabolizer, you're going to have essentially ineffective levels in the system. But if you're an ultra-rapid metabolizer, you're going to have adverse events for pro-drug. And I mention this again because this is, again, an important concept to keep in mind. So as we mentioned last time, in terms of pharmacokinetic drug interactions, there's enzyme induction. So, other than pharmacogenetics, we have to think about things like this, like enzyme induction. We talked about Tegretol and phenobarb and rifampin and St. John's wort last time is very powerful enzyme inducers. And then, of course, there are very specific enzyme inhibition of the cytochrome P450 enzymes, and that can create havoc. And obviously, a substrate that is, metabolized by the enzyme. I'm showing you this table again now. This time, the opioid medications are highlighted in red. So, for example, with 2D6, we have hydrocodone that is metabolized. Oxycodone, also to a certain extent, is metabolized by 2D6. Codeine, as you know, is a prodrug and is metabolized by 2D6. And with 3A4, we have fentanyl and methadone and meperidine that are metabolized by this particular pathway. An expanded version of the 2D6, again, if you look at the analgesics that I have highlighted there in yellow, codeine, dihydrocodeine, hydrocodone, oxycodone, tramadol, and methadone, all metabolized to a certain extent, or maybe as the sole enzyme by 2D6. And I mentioned the antidepressants here as well and the antipsychotics because they're frequently used in the chronic pain management scenario. Again, with 2D6, many caveats to keep in mind. This particular enzyme is strongly inhibited, and again, this is a reminder from last time, Prozac or fluoxetine, paroxetine or Paxil, Wellbutrin or bupropion. These are very powerful inhibitors of 2D6 and certainly can convert somebody that is an extensive or normal metabolizer to a poor metabolizer when you have this inhibitor on board. Moderate inhibitors are drugs like Cymbalta. Weak inhibitors are Tagamet, Celexa, Lexapro, and Luvox, and maybe even risperidone or Risperdal as an antipsychotic. Dose-dependent just means that at the lower dosages of Zoloft, maybe 25 or 50 milligrams, you're not going to see 2D6 inhibition. But if you go to the higher dosage level of 200 milligrams, you're going to see that. 3A4 is another very important enzyme. As you well know, metabolizes about 50% of the drugs that we consume. The polymorphisms with 3A4 and 5 are not very clear-cut, and it doesn't, it's not very clearly defined in the literature which polymorphisms are really important. But nonetheless, the drug interactions with 3A4 are very important, and anticonvulsants like Tegretol or carbamazepine are metabolized by 3A4. For narcotics, we've got fentanyl, methadone, and meperidine. And even the hypnotics, if you think about the Z drugs like Ambien and Sonata and Lunesta, and some of the drugs used for anti-anxiety, they are metabolized by 3A4. Now 3A4, again, as I mentioned, has very powerful inhibitors, and this is where some of these problems happen. So if somebody has an infection, a fungal infection, and even are put on a short course of ketoconazole, or the other antifungals, they're very powerful inhibitors. So if you're on methadone, you're going to have methadone toxicity even in that short length of time. Luvox or fluvoxamine can be used as an antidepressant, is used for OCD, is a powerful inhibitor. Calcium channel blockers, like diltiazem, verapamil. I'm trying to remember the trade names as I go along here. Many of these drugs, of course, are generic. The macrolide antibiotics, this is another very important story. Erythromycin, if you're being treated, for a, upper respiratory tract infection, Biaxin, for example. Powerful inhibitors of 3A4. The HIV protease inhibitors are powerful inhibitors of 3A4. And the inducers, Tegretol and phenobarb and phenytoin, very powerful inducers of these enzymes. What does that mean? So if you add Tegretol to a drug that is metabolized by 3A4, after about 2 or 3 weeks, you're going to chew up the drug much faster, and you may need higher dosages. Again, it's taking the example of methadone. If you add Tegretol, after a while, the system is induced by carbamazepine or Tegretol, and you may need higher dosages of methadone to get the pain relief, or if you're using it, in a methadone maintenance clinic for that matter. Phenytoin, same story, and St. John's wort, as I mentioned, again, a powerful inducer of 3A4. So going back to opioids now, after looking at some of this information with drug interactions, they are very important drugs in the entire spectrum of pain management. There's a lot of scrutiny right now by CMS and so on because of not just illegal drug abuse, but prescription drug abuse. Very, very high levels in this country now have certainly increased over the last 10 years. They don't have any ceiling effect, meaning that you can use pretty large doses, and people do develop tolerance over time, and sometimes large doses are indeed needed. You can titrate them very simply and easily. No end organ toxicity, meaning you don't have really a liver and kidney toxicity from these drugs. And you have a wide variety of formulations, dosage strength and routes of administration with many of these medications. Some of the adverse effects with opioids, that's in the next slide. The common ones on the left-hand column are constipation, nausea, somnolence, dizziness, vomiting, and you see that often when somebody's just started on it. But over time, you do develop tolerance over the next 1 to 10 days and 2 or 3 weeks. Constipation is one side effect with opioids that people do not develop tolerance to. So many of the pain guidelines tell you that you really have to treat constipation proactively when somebody is even for 3 or 4 days of, Vicodin. For example, the dentists are very fond of prescribing Vicodin for any dental procedure, and forget to tell people, if they're taking it for 4 or 5 days, that they should be careful, and maybe have a stool softener on board, and maybe use Metamucil, but then of course you want to hydrate when you use things like that, and especially in the elderly that becomes a major issue. The more serious side effects with opioids are respiratory depression, certainly stopping breathing, apnea for a very short amount of time, respiratory arrest, which is potentially fatal, of course, circulatory depression, fatal, of course, and some of the drug interactions can lead to very high levels of these opioids, and that's why we have to be careful when we look at this. So let's look at a case scenario. So Mrs. Jones is 79 years of age. She has pneumonia. She's been treated with antibiotics with codeine, and codeine is a great cough suppressant, and so it's used more often as a cough suppressant than as a pain reliever. On treatment day 2, she is found unresponsive, so she's not had a whole lot. She's had maybe, 15 milligrams every 3 hours or something like this. And she's unresponsive, and she's transferred into the ICU. But fortunately, with supportive things like, intubation and respirator, she indeed recovers and is a success story, even though, it could have gone the bad way. So what happened in this instance? Well, there was a nice case report in the New England Journal of Medicine talking about codeine intoxication associated with ultra-rapid 2D6 metabolism. Keep in mind, codeine is a prodrug. It needs 2D6 for conversion to morphine. And there's been more case reports since that time, especially in neonates with breastfeeding mothers in the US as well as in Canada. So consequently, the FDA put some guidance in the codeine package insert in 2007. And they talked about the fact that, if you're a 2D6 genotype, you may convert codeine to its active metabolite more rapidly and completely than other people, and especially in nursing mothers. And so you have to be very careful. And of course, this applies to older patients as well, even when you're using codeine, not as a pain reliever, but as a cough suppressant. Keep in mind that if people don't know that you are an ultra-rapid metabolizer, and you may use more amounts of codeine to get pain relief, codeine, it has a fair number of side effects, lots of nausea, lots of vomiting, lots of constipation. You may not get any pain relief, but the bad effects of codeine will continue. What about some of the other opioids like tramadol? It is converted to a more active drug as well. Tramadol is Ultram, that is one of the trade names, but there have been some studies in the literature and in experience where if you're using Paxil, which is a powerful 2D6 inhibitor, you can decrease the efficacy of tramadol. Again, because why? Because tramadol requires 2D6 for conversion to the active compound, and Paxil, being a powerful inhibitor, decreases the efficacy of tramadol. Hydrocodone or Vicodin, as I mentioned, frequently used pain reliever, is converted to hydromorphone by 2D6. Hydrocodone by itself is active as well, but hydromorphone is more potent, and about 10% of Caucasians that are, poor metabolizers, they may not get the benefit of conversion to hydromorphone. And so 2D6 affects the pain relief through hydrocodone. And there is also 3A4, which is the enzyme that metabolizes hydrocodone to norhydrocodone, which is not active. But if you have a 3A4 inhibitor on board, you're going to have large amounts of hydrocodone and not converted to a metabolite that is not active. And so you're going to have more somnolence, more sleepiness and more constipation, more, memory loss, and some of the side effects we talked about. What about oxycodone? Again, a very popular pain reliever. It is metabolized by 2D6 3A4, so remember those, status when the genotyping is done. Oxymorphone is an important pain reliever. It is converted, it is formed by, oxycodone being metabolized by 2D6. It is not as potent as oxycodone, but certainly conversion to oxymorphone is important. Noroxycodone is less active, just like norhydro, in the previous slide, the norhydrocodone. So the nor drugs seem to be less active or maybe not even have any activity. So with oxycodone, 2D6 inhibition and 3A4 inhibitors definitely become relevant. What about morphine? This is a question I get fairly often. What the great thing about morphine is that cytochrome P450 does not play a major role at all, very few drug interactions, and it is really metabolized by the body to what we call a glucuronide. The liver converts it to 3-hydroxy and 6-hydroxyglucuronide, so cytochrome P450 doesn't play a role. So if you have issues with being an ultra-rapid metabolizer or poor metabolizer, then morphine may be the right analgesic for you. You certainly need to decrease the dose of morphine in connection with decreased kidney function. What about methadone? As I mentioned, it's a highly effective analgesic, has a long and variable half-life. So it really needs to be used by people that are very familiar with it, needs special expertise, does not depend on active metabolites, so it's not a prodrug. It is metabolized by 3A4 and 2B6, for which we don't do a lot of genotyping, and a minor pathway for methadone is also 2D6. So many, many drug interactions you can well imagine with a 3A4 category of inhibitors and inducers, and so that needs to be kept in mind. What about fentanyl? Again, it's a very potent opioid. It doesn't depend on active metabolites, just like morphine and methadone. It is metabolized by 3A4. So again, lots of drug-drug interactions happen with 3A4 with inhibitors and inducers. So let's go to another case.
Manju, I'm sorry, this is Ken Wallace. I'd like to interrupt. There's a phone caller. If you've called in on a phone, please mute your phone. I don't have control of the dashboard anymore, so I can't mute you. But if you are on the phone, please mute your phone. Thank you.
Okay, sorry about that. Yeah, I was listening to that too, but I wasn't sure. I was right in the midst of my slide, so thank you. So I hope that, you know, my voice and audio wasn't too bad coming across. So we're now coming to the end with another case scenario. And here is a case scenario which is actually in a pediatric patient, which was published in Pediatrics 2010. And this is a 5-year-old that was given hydrocodone for cough. Again, it's a good cough suppressant associated with an upper respiratory tract infection. And this little 5-year-old was also prescribed Biaxin, you know, for an ear infection. She was, the parents were instructed to give 1 teaspoonful, 5 milligrams, 3 times a day for cough. The family actually gave 30 milligrams, which is twice the dose that is recommended for a 5-year-old patient, you know, 5-year-old period, you know, so they gave twice the dose, 30 milligrams in 24 hours. The patient was unresponsive the following day. Unfortunately, this patient died, and on autopsy, they found hydrocodone was found in very toxic levels, but they didn't find any hydromorphone. So bells should be ringing right now, meaning that hydrocodone was not converted to hydromorphone. This 5-year-old was a poor metabolizer, so no hydromorphone was formed. A lot of hydrocodone found in the system, plus Biaxin, as I mentioned in an earlier slide, is a cytochrome P450-3A4 inhibitor, pretty powerful. So you couldn't even convert it to nor hydromorphone, which is a much less active metabolite. So there was like a perfect storm of being a poor metabolizer and having a cytochrome P450-3A4 on board, and unfortunately led to the death of this 5-year-old. So the top drug-drug interactions in pain and psychiatry, again, like I mentioned last time, lots of crossover combinations involving Prozac, Paxil, Wellbutrin, because they are powerful 2D6 inhibitors, combinations with, you know, especially for prodrugs, combining it with these powerful 2D6 inhibitors and maybe even 3A4 inhibitors like antifungals, Luvox and erythromycin and Biaxin, which are 3A4 inhibitors, because not all drugs are just metabolized by 2D6. Some have minor pathways through 3A4. Tegretol is a powerful inducer, just like Dilantin and St. John's wort, and many patients do use it. You have to look for a herbal drug history. So, you know, when I teach at the College of Pharmacy, we tell our students and our fellows that they really should, you know, ask the patients what else are they using other than prescription drugs, and it's really to elicit any other herbal medications that they might be using. So that is the last slide, and I'd like to open it up for Q&A. Thank you very much, and I hope it came across well. Okay, I'm open for Q&A.
Okay, so what I'm going to do is ask that everybody on the webinar, if you have a question for Manju, please type it in the chat box. We've had some problems unmuting everybody with feedback, but we will, I'm going to go ahead and try to do that. If we have some problems, I'm going to mute it back again, but if you could mute yourself, if you're not asking a question, that might work the best. So here we go.
Yeah, it's Stanley's cell number coming. What do you?
Yeah, let's use the chat box.
Okay, let's see. How to calculate, what's that? Let's see. How to calculate the recommended dose of codeine in cytochrome P450 morphism, particularly in IM and in case of 3A4 inhibition. Well, this is hard to do. You can't just calculate a dose. You just have to see what the patient response is going to be. So for example, you know, if you are a poor metabolizer, you are not going to convert it to morphine. You may need higher doses of codeine. Codeine is really not a great analgesic. Most of the pain physicians and pain people I'm familiar with don't use codeine very much as a pain reliever. I know it's there in many combinations with Tylenol and everything, but you just have to, if you know the genotype, then you just have to titrate the dose and see what kind of response you're going to be getting. So I hope that answers that. So let's see. When an inhibitor like Prozac is given and Plavix, let's see, when an inhibitor like Prozac is given and Plavix after a stent, is it a given that he becomes a 2C19 poor metabolizer, or just a possibility? First of all, Prozac or fluoxetine, actually you're right. You know, mostly it inhibits 2D6, to a certain extent 3A4, but it also has some inhibition on 2C19. So it is not a given just because everybody is different. So that is why we say there's a potential drug interaction. So you again, you have to see what is going to happen and maybe adjust the dose accordingly. The problem is that there's not a lot of algorithms out there for adjusting the dose of Plavix in relationship to being an ultra-rapid or a poor metabolizer. What people are doing now, because Plavix is generic, and there are other drugs out there as well, like Prasugrel or Effient or Brilinta, which is another antiplatelet. If there are complicated scenarios of drugs on board that are 2C19 inhibitors, and they have a genotype that is not conducive, they're just switching to the other antiplatelet. And I think that is what people are trying to do. Let's see, go on to the next question. Is there any clinical dosing algorithm for any of the cytochrome P450 enzymes to apply for pain medication? Nope. There isn't any algorithm per se, but I think knowing this information and understanding it, especially, you know, the people that are prescribing this and, you know, in pain clinics, whether you're a physician assistant or nurse practitioner, or, you know, knowing this, then you can really titrate the dose back and forth and monitor for response. But there's never, you know, that's why medicine is not so much of a science, it's more of an art, because, you know, people are different, and you get into trouble when you have a cookie cutter approach like a recipe or fixed dosing algorithms. But I think knowing this baseline information really helps people understand. Let's see, I'm going down the list here. Does any of the enzymes play similar role in the metabolism of pure opioid antagonist? We're talking about naloxone or naltrexone, which are pure opioid antagonists. Off the cuff, I don't think so, but I'll have to look into that. They are, of course, used very rarely. When you use Narcan or naloxone or naltrexone, you're going to be very, very careful, because you can have very precipitous withdrawal in a patient if you just, you know, add that drug on board, because you are really antagonizing the opioid receptors. So people have to, you know, you have to be doing it with support systems and very, very carefully. But offhand, I cannot really think of a cytochrome P450 interaction with Narcan and naltrexone. For someone who is a poor metabolizer and 2D6 and is not getting pain relief, which oral drugs would you recommend for a physician to use? That's a good question. I would go with morphine. You know, morphine is, you know, it's got many different dosage forms out there. You know, sprinkles and capsules and tablets and chewables and syrups and IM and, you know, and long acting and extended release and sustained release. So I would go with morphine. And again, keep in mind, this is for moderate to severe pain relief. You're not just going to jump to morphine for mild pain relief. So that is what I would recommend. And certainly if you're not an opioid naive patient, meaning that you've used opioids before, people convert to a fentanyl patch, which is once every 72 hours, and that is also a drug that is not a prodrug, but of course it's a topical drug, not an oral drug. But many people find a lot of relief with fentanyl, but it needs to be used not in people that are opioid naive. Hope that answers that one. Let's see, I'm going down the road here. Is there any clinical acceptable guidelines for pain medication modifications based on cytochrome P450 genotyping? Excellent question. There is actually, I'm trying to remember this now. It's this called, there's a codium, there is a consortium of people. It's called, what is it called? Pharmacogenetics Intervention Consortium or something like that. They frequently meet. This is an independent panel. This is not part of the FDA. They look at evidence. This is called CPIC or something like that as an acronym. They have put out guidelines for codeine, dosages and what to do with codeine in the instance of genotyping. I think they've also addressed tramadol. And I can certainly try to find, the resource online, because I think it's called CPIC, and they've got some guidelines along these lines. But one thing you have to keep in mind is about guidelines is that guidelines are time-sensitive documents. So once guidelines are published, the way that the literature is evolving in this arena, it's very difficult to just stick with guidelines and not update yourself. And so be very careful with using guidelines. It's nice to have a consensus of people publishing something or evidence-based, but guidelines get very outmoded very quickly. And so you gotta keep that in mind. But I will look and see if I can find that CPIC and send it to Kenny, and he can pass it on to everybody. Well, I don't see any other questions, and great questions, you guys. You're thinking out there, so that's very, very good. Thank you for being here today, and if there's anything else, I'm still here.
Manju, thank you very much. If you think of other questions, just send us an email, and we'll have those addressed.
Okay, great. I hope you probably didn't get some very precise answers like you would like to have, but then that's again because, like I said, medicine is more of an art than science. It's really a combination of science and art, and that is why we don't have a real cookie cutter, precise algorithms and so on to deal with this. But there are guidelines, yes, and I've tried to, over the last 3, webinars that we've done, I've tried to impart those to you, and hopefully that has, increased your understanding.